Okay. Thank you all for joining us today. We have Lindsay Corcoran from Stroudwater. She's really been our contact, our go-to, our project lead for our Swing Bed Directory project. In addition to signing up for the directory, entering your data, checking your competencies, developing your marketing tool, we also have a series of educational webinars, and that's what this one is today. This is technically about our second educational webinar. The previous one was about marketing and best practices of getting your program out there. Today we're going to be talking about discharge planning. So if you guys have any questions at all, you can unmute yourselves. I'll also be watching the chat. Again, we are recording this and we will get it on our YouTube channel and sent out as quickly as possible. And also Lindsay will be sharing the slides with us too. So with that said, I'm going to turn it over to Lindsay, but just let me know if you need anything.
Thank you, Laura. So welcome everyone. I think it's good afternoon. I would love participation. I think I had mentioned this at the end of our last education webinar, that this webinar, love to have folks share some of the things that they are doing around discharge planning for your swing bed patients. And so today we're going to talk a little bit about, discharge planning, some best practices. I do have a very wordy section around policies and procedures. And so that's going to be a good time for you to review the slide deck and almost do like a self-assessment. Look at what you all have in-house for your policies and procedures and compare it to some of the policies and procedures that I'm going to share around discharge planning, and how does that apply to your programs? Maybe there's, just it's a good tool to just kind of do a check. And maybe your policies are way better than the ones that I'm including, and that's totally fine. It's just an opportunity to kind of reassess yourself. And then I have some kind of key takeaways or for you all, checklists, things that make our lives a little bit easier. So again, would love to hear, what you all are doing. This is a great opportunity. We have a bunch of folks on the phone today, and on the webinar, representing hospitals within your state. And, this is an opportunity to share some of the great things that you all are doing with other people. So lots of participation. Okay. So really, why are we focusing on discharge planning? So if you have participated in the Swing Bed Directory project and you've gone into the portal and you've inputted your data, you would have noticed that we asked some questions around care transitions. And there was around 5 questions really around discharge. What do you do with your patients that are being discharged from your swing bed program? And we wanted to, get a better understanding if you had some of these kind of best practices, instilled in your organizations. And so the data had shown that there was a lot of, maybe some opportunities for tightening up our discharge planning in our processes related to discharging of our swing beds. So that's sort of the background of why we want to touch on this topic a little bit. So what is discharge planning? It's really around the process of identifying and preparing your patient for any healthcare needs after they leave the hospital. So whether that be from your inpatient unit or from, swing bed, or if you're, discharging a patient from your skilled nursing facility, there's a process that involves discharge, and there's a planning process that goes along with that. The Critical Access Hospital State Operations Manual defines transfer and discharge as any movement of a patient to a bed outside of a certified facility. So whether that's either in the same physical plant or not. So one important key takeaway, and I think this is going to come up a whole lot in this slide deck, is around discharge planning should never be done in isolation. It is not just a nurse that creates this discharge plan for the patient, and it's just a whole bunch of checks, and it's a discharge summary that gets plopped into the patient's medical record. This is a process that involves both patient and family, and we'll go into more in depth around I think personally, the most important part of a successful planning process is around the interdisciplinary team. So why is, discharge planning important? It really contributes to positive patient outcomes. If you have a tight discharge planning process and discharge process within your organization, studies have shown that there's reductions in unplanned readmissions. Studies have also shown that, approximately 20% of discharge patients experience some type of adverse event. And so if we are, have these processes in place to try to minimize that, that's the goal is really to improve those health outcomes and reduce those unplanned readmissions, as well as improving patient and family satisfaction when they're, involved in their care. There's that, they feel like they're involved in their care and they're more satisfied, and, hopefully leading to better health outcomes. So, as you are all aware, I'm sure you are all aware, back in 2019, CMS did a pretty big overhaul on and applied a discharge planning set of regulations. And those were approved back in 2019. They apply to, every healthcare entity that's participating in both Medicare and Medicaid, critical access hospitals, home health agency, you name it. And the rule is really around requiring that discharge planning process be in place that really outlines patient goals and their treatment preferences. And then there's also some, language in there around how they access medical records and how they are, discharged and transferred between different healthcare settings. So a little bit more, just looking at the critical access hospital side, there's the regulations around having an effective discharge planning process. And again, it's really around the focus on patients' goals, treatment preferences, and it includes, as I said before, this is going to come up a whole lot, includes the patient and family or support person in the discharge planning for post-discharge care. So, post-discharge care being discharge to home, discharge to a SNF, nursing home, hospice, home with home health, any type of that after hospital stay. And then there's also other components within the discharge planning regulations, and one around the transfer of medical information is sent and how it incorporates patient goals and preferences. Also outlines the discharge planning process. And one of the key where I underlined here is around identifying those patients at an early stage of their hospitalization, likely to suffer an adverse health consequence. So, that makes me think, do we in our hospitals have a way of identifying patients that may be at risk for readmission? Are we utilizing a best practice readmission risk assessment tool, such as the LACE tool or modified LACE tool? A lot of hospitals have these tools already built into their EHR. And so they're able to kind of build that into their admission kind of workflows. But that certainly is somewhere where we want to focus, that we want to make sure that we are assessing, patients on admission for, any type of readmission risk that may come up. And some other, specific components to critical access hospital within the discharge planning regulations are around that a discharge plan is developed by a qualified professional. So whether that's a nurse or a social worker within the hospital, that regular reevaluations and updates are the discharge plan is made, and whenever necessary. And then the assessment of the process of your discharge planning process is done regularly. And this is, I really like this part of it, because it really has a way of understanding, it's the checks and balances. It's making sure that our process is reviewed on a regular basis, and are there areas for improvement? Are we reviewing patients and their discharge plans that may have had a readmission? So do we have a readmission audit tool somewhere built into our workflows? Are we looking at those 30-day readmissions and trying to understand, why they returned? How can we prevent a readmission the next time, and having some type of audit tool to help assess those patients that may have been a readmission. And then we talked about this on the previous webinar, but the last component being around the post-acute care selection process, where we have to have we can give the patient a list, and that has relative applicable data such as quality for any kind of post-acute care entity. That's also included in the discharge planning regulation. And then also included, and this is a separate outside of the 2019 discharge planning rule, was the condition of participation for critical access hospital swing beds. They must be in compliance with the SNF requirements. And what we'll do is you can see here that there is, a call out to discharge planning through the various care plans, and the comprehensive care plans and the comprehensive assessments. So there's certainly a call out to the discharge planning process within the conditions of participation. Also within that, and then so just taking kind of a next step going down below, related to the conditions of participation, is the admission, transfer, and discharge. I'm not going to go through all of this, but there's certainly some relevant information that needs to be provided on discharge of a patient. So just looking at that one, I'm going to just highlight is around the discharge summary. So what are we including in that discharge summary? We know that, and so this here is really the next step on that discharge summary. A physician must prepare a discharge summary whenever the hospital, the critical access hospital, anticipates a discharge of a patient from the swing bed program. And then, so the discharge summary should really include a summary of the patient's stay and any of the services that they received. Patient's healthcare status at the time of discharge. And this info has to, be readily available to be released to with the patient's consent, to any, family member or any authorized agency. And what else must be included in the discharge summary? Well, where the patient is going, what's their destination, and then their post-discharge plan of care. So what is, and this is, where the family comes into play, is what are, is the family, ready to support that patient when they come home? What are the continuing care needs after discharge? How will those needs be met? If the home is not safe, does the home need to have handrails put in or a ramp put in for the patient to, safely ambulate into the home that they are going to? What are some of the education that was provided to the patient? If it's a, disease specific education, was that provided? And what kind of method did you use the teach back method, for instance, with the patient and the family prior to discharge? Should all be included in that discharge summary. Let's see. And then, so we went, high level, looking at what's from a regulatory kind of, what's been outlined from a regulatory standpoint, but then, we want to distill that down and to say, okay, well, that's great, but what are some of the best practices? What can we do at our organizations to really make this work for us? And so, when we think of discharge planning, it's multi-dimensional. There's a lot of stuff going on. And what are some of, and I'd love to hear, and maybe when we open it up to discussion, is around if anyone has reviewed your discharge planning process at all recently. Have you been able to identify areas where you can improve the process, or are there gaps in your process? A lot of times when you are getting some readmissions, that may be the time where you do reassess your discharge planning process. But some of the areas that can improve the discharge planning process are around the interdisciplinary communication. I think this is essential. When you have different departments having to come together in this team, there's organizations that may be really siloed, and that when you have to come together in this team aspect, communication may not always be what's the best, and this, I think, is going to be very essential when we're planning, the needs and the care of the patient. If somebody doesn't check their email, for instance, and prefers, discussing patient needs over the phone, we need to figure out how to communicate better within our team. And some of the other areas to improve the discharge planning process is around standardization. Standardization of our educational materials that we may have, standardization around any of the forms or the checklists that we have. Those, should be reviewed, making sure that they're easy to access, easy to utilize. They flow into the medical record if they're electronically. There's a process that happens if they have to be scanned into the medical record. We want to make sure that things are standardized, and anybody that comes into a role can be able to kind of pick up that process because things are standardized. Making sure that we have instructions, whether that's instructions for our own staff, maybe that's instructions related to a policy and a procedure, or instructions for the patient, certainly helps with that discharge planning process. And then one I want to point out is around limiting the medical jargon. So when you're talking to a patient, when you're giving patients discharge information, is it at their, healthcare literacy? That's when we start to talk about social determinants of health, healthcare literacy is a huge aspect of that. And so making sure that the things that we give our patients, how we talk to our patients is at their, at an appropriate level for comprehension. Some of those are some of the things that can help improve that discharge planning process. But then on the other side, what are some of the factors that make this process complex? We have, patient issues, again, communication difficulties, documentation problems, the time pressure on getting everything together, meeting as a team, making sure that we have everything together in a timely manner, to get this patient safely, discharged. And then we have policy issues. Things are always changing. We had we're still in the public health emergency. And so that at the time, there's all these different waivers. So what's applicable to us, lots of different changes, lots of things to keep up with. So those can certainly impact our discharge planning process. And and I'm sure you'll nod your head with some of these, but, some of the patient issues, what may impact a potential readmission potentially, is it, we really must consider each one of these buckets: medication management, failure to understand discharge instructions, complexity of the patient condition. We really must consider each one of these and really self-assess, what are we doing at our hospital to minimize some of these issues. Not scheduling or attending follow-up appointments. Are we making those post-discharge follow-up phone calls to making sure that those patients are getting seen for their follow-up appointments? Some of these things that we in our hospitals and internally, although they may be patient issues, these are some things that we can help minimize a bit. So, I think that the key to around a really strong discharge planning process is around the interdisciplinary team. No one should take on the swing bed program and in having to develop all these care plans and making sure that the patients are meeting their established goals in isolation. It really needs to be around this interdisciplinary team. And it's multifactorial. We just need to have a real good interdisciplinary team. So some of the key things to consider as we go through our discharge planning process is beginning discharge on admission. And so we like to see that, that discharge planning happens on admission or within 24 hours after admission. Sometimes the patient comes in on a Friday, but, the team is not able to start that within, within 24 hours. So, some of this, understanding what their discharge needs may be, we want to maybe look at, what their home life is. Do they have a primary caregiver available? What are some of the community resources that they may have? What type of health coverage do they have? And then, are we going to have to look for arranging DME or transportation? Those are the things that we can start to do on admission in anticipation of their discharge. So what are some, what's in the middle? Where we're going along, our patient is getting their rehab. We are updating our care plans and, so what's going on? The involvement of the family is key. So, establishing a discharge planning meeting, in that being held on admission and prior to discharge, involving the family and the patient in goal setting, and then updating those, goals in discussing progress to those established goals needs to be occurring, as well as informing the patient and family about the anticipated discharge, updating the family and the patient if that anticipated discharge changes, providing that ongoing education that, as we're in, planning for an anticipated discharge, what are the things that they need to be thinking about when they get home? How are they going to, be able to ambulate, from the bed to the toilet and maybe need, some assistance, or if they, in the use of a walker that they may need to bring home, providing some of that ongoing education and involving that family member in that ongoing education as well. And then, at discharge, there's the discharge instructions, the follow-ups, the medication, those are the things that we need to check off to make sure that we are providing our patients at discharge. And then I do want to spend a little time on discharge phone calls. So that if you looked at the swing bed directory self-assessment, and, that was one that we had asked about. One of the items within the care transitions are around, are you providing discharge follow-up phone calls? And so, I think this is a lot of times hospitals will just do discharge follow-up phone calls for their inpatients, or they may be doing it for the emergency department, but they're only doing it for the, their chronic condition patients. And so we think, discharge follow-up phone calls should be made to anybody really discharged. It really is an effective use to provide, an opportunity for the patient to ask any questions. Oftentimes patients are flooded with so much information at discharge, and all they want to do is just get home. And so once they're home, they're able to, maybe they can look through their discharge instructions, and maybe there's a question that they want to ask. And so we can, proactively reach out to that patient to make sure that question can be answered. Medications, that's always been that hot topic, if you will, where patients are confused about their medications when they go home. And I can't remember what dose I was supposed to have or what pill I was supposed to have. So again, having a touch base with the patient is essential post discharge. We can also, monitor their recovery progress. And then we also can check in to make sure that they did, make those follow-up appointments. If they need to schedule them themselves, have they been scheduled? If we scheduled them for them, did they go to their follow-up appointment? So it's really a great quality of care, patient follow-up, process, if you will. So, studies have shown that these discharge follow-up phone calls, real positive feedback from both patient and nurses, or anybody that is making those phone calls, because you've closed the loop with patient care. That not only are they just discharged from your hospital, but you're providing that continuation and of care, to when they do come home. And then research have also shown that more than 90% of the patients have questions post-discharge. So we can't just assume that your patient is not going to have any questions. And we want to make sure that we are proactive in making sure that we are answering and following up with those patients. So what are some measures for success? And, when we look at our own swing bed patients, and how they're, what happens to them post-discharge, some of the things that we can start measuring is around the percent of patients that were rehospitalized after a swing bed admission. So did they end up back in our inpatient beds? And what was that percentage? And what about the percentage of readmissions to acute within 30 days? And then what we really want to see is the percent of swing bed patients who were discharged to the community. And so those are some of the things that we can be tracking, and to really measure the success of our own swing bed program. If we are able to really implement some of these discharge planning processes, we have a real strong process to pull together, including, an interdisciplinary team. We have, best practice tools that we can use and checklists, and ensuring that these things are really sturdy within our organizations. Then we'll see some real measures of success around the discharge to community. I guess I shouldn't have called that slide measures of success, because unless you have a really low return to acute care or return to the acute care post-discharge, your readmission rates are low, then I guess that would be a measure of success. Let me take a breath. Does anyone have any questions? I know I've been talking for 30 minutes or so, but does anyone want to share anything about their discharge planning process, or if they've had success doing, something really cool within their discharge planning process, that you have a great, person in your organization that brings together the patient and the family, or you have a really cool checklist that you use, or a tool. Anybody want to share anything?
Lindsay, this is Emily from O'Keene. We do the discharge planning within 24 hours of discharge, but for our swing bed, and this is on any patient that's admitted, observation, inpatient and swing.
Yep.
But we also do a swing bed meeting once a week, every 7 days, with our patients in skilled nursing. We invite the family, the caregiver, the doctors there, and the physical therapy or occupational therapy, either one that can come. We go over where they're at on goals, their discharge plan, any questions, concerns the family has. That way we can just keep, and we reevaluate every 7 days. So if we're going to discharge within the week, we let them know, hey, Friday, we're going to probably be ready for discharge, or let's reevaluate in another 7 days, just to give them a good heads up.
Yeah. I mean, that's great. I mean, that's wonderful. I have a question. What kind of feedback do you get from families?
It's great. I mean, they're usually they always try to be there. A lot of times they'll have a concern. Hey, they were having issues with this at the house. Can we work on that? We've had several that have appreciated, given us the appreciation for having these swing bed meetings, so that they know where they're at, in their goals and what our plan is. So there's great feedback.
That's great. I think it's such a good, a lot of times, for your inpatient admissions, your acute patients, there's not a whole lot of, family interaction. I mean, you try to, but it's just, you're not, doing the progression, try to, the touch bases every 7 days, it's just not the same. I think for the swing bed, there's a lot more in family involvement. They're trying to get home, and really be able to go back to life before rehab. What about how have folks, during COVID and when we were totally locked down, and maybe some of your facilities are still, not allowing visitors, how have we adjusted to making sure that we've involved the family in some of our discharge planning processes? Or is it something that we just weren't able to do? Did anyone do like Zoom meetings or FaceTime? Were we able to leverage just phone consults with the family? Felicia said phone calls with the family. So that's great. Good. Okay. So this next section is, I would say it's the opportunity for when you get the slide deck. If you showed up late to joining the webinar, this is going to be the section that when you do get the slide deck, just, look at some of your policies and procedures and compare it to some of the policies and procedures that I've selected for this webinar. And one being around the interdisciplinary team. And so, what does the policy and procedure related to the interdisciplinary team look like? What do we, have we determined a schedule of when we have meetings, and who is included in our interdisciplinary team? What's the process? What are the items that this team is going to complete, whether it's a admission assessment that's done by each one of the disciplines on the interdisciplinary team, the discharge planning assessment involving the patient and family. So how does that work? How do we inform the patient and family around the process that we've laid out? These are some of the kind of the key steps within this process. And again, sorry for all the words. It's just, this is the type of material that you get when you look at policies and procedures. I'm sure you all know. But again, how are we going to share some of the outcome data within our team? Again, the schedule of meeting with the patient and family. Okeen just shared that they're doing their meetings every 7 days. So that, can be included in your process here. And so, what are we assessing from a care team perspective on the ongoing needs of the patient, and agreeing as a team about the anticipated discharge date. And so there are some specific interdisciplinary team processes related to the care manager. And I'll have a few other slides just around care management, the care management role, but looking at, what type of forms that we use, whether it's a checklist or each discipline using some type of form that assesses the needs of the patient and their goals as well. And then making sure that we have, whether or not we have huddles, are those daily huddles. I think it's always good, instead of, we may have a large swing bed team meeting every 7 days to discuss patient care, but can we have these quick check-ins and these quick huddles to discuss any type of medical issues that may come up, a change in condition, that we can just do these quick check-ins, would be a good process to implement. And then what's the role of the care manager? I don't know, I've been to a few facilities that there is no care manager. And so there's no care management team, there's no care manager. And so that's sometimes hard when there's not somebody that's their focus is on this process. But, how can we implement some parts of this process and ensure that some of these needs are being met? So, what's the involvement of care management, with the patient and the family? When does that happen? As I had said before, there's on admission, we need to, have that discharge planning meeting, first, and then, looking over and doing a discharge planning assessment within 24 hours, as I had mentioned before. And then, making sure that we are reviewing that discharge planning assessment. That care manager is obviously a part of that interdisciplinary team, and making sure, that documentation, progress notes, daily encounters are all complete. This is the transfer and discharge. So this is one of the conditions of participation that's related to the swing bed for critical access hospitals, and one of the SNF conditions of participation. And I'll have a checklist, if you will, that will help meet this policy and procedure that I've included in the slide deck as well. So again, what are the needs, and how, this policy here is what conditions a patient should be transferred or discharged from any type of skilled program. So we really want to have this policy in place to provide staff and the team a framework for making some of these decisions. I think instead of going through every single one of these bullets within this policy, I'll make sure that we highlight them on that checklist. It's much easier to look at it in kind of a checklist form. And I do want to make note that these are not all of the policies and procedures you would need for your swing bed program. I just picked these ones because they, kind of outline some of the essential components of discharge planning. And then, having a policy or procedure around planned discharge. So, the policy is around patients will be given 48 hours notice of an anticipated end to their services or discharge. Again, this may not be something that you have in your policies and procedures, but something to maybe consider. Again, I apologize for the wordiness. It's a lot of words. And lastly, is around your comprehensive care plans. And so, making sure those include, all of the discharge pre-admission information, what's the anticipated discharge destination, what's the anticipated discharge functional status of the patient, what's their anticipated length of stay. This is something that's got to need to be updated. How are all of the different disciplines progressing towards or how is the patient progressing towards their established goals? And so we want to make sure that all of these things are included in our care plan. And then the last one here, if and we need to make sure that whether or not any of the problems or the goals were not met and why, and we want to make sure that that's also included. So here, I wanted to, provide some takeaways. Again, maybe you already have some of these checklists. Maybe you don't. Maybe it's an opportunity to do the look back and compare what you all have. This here is a swing bed discharge planning and goal setting form. So it really goes through all the different areas that we want to make sure that we assess, and we can, this is part of our discharge planning worksheet. It has where the patient is going to be potentially discharged home. Are there any needs around assistive devices? What are the patient's verbalized goal? What are their discharge goals? So again, this here would be a good form to implement around for discharge planning. This is a discharge plan of care for your swing bed. So, you know how I talked about patient teaching. So what type of education was provided to the patient? That's included here. Some, you know, what medications, any medical equipment or their DME requirements. What are some of their outside resources? We had talked about that. What are their needs as it relates to transportation? And further instructions. So this here can be a form for your discharge plan. And then last form here is around the transfer or discharge checklist. So this is completed prior to transfer or discharge, and it really helps to determine any reasons for transfer and discharge. Again, you know, it's around the interdisciplinary team has looked over this patient's plan of care. And then the transfer or discharge was due to the following. And, you know, a lot of times it's just the transfer or discharge is appropriate because the patient's health has improved. So they no longer need, you know, swing bed services or something. And so that one would be checked. And so again, this meets the needs of that transfer and discharge policy and procedure, and making sure that, you know, these various entities are notified and the following documentation is in place. So that's the last slide I have. I'd love to, you know, hear some more, you know, what's worked really well for your hospital as it relates to discharge planning for your swing bed patients, and maybe what's not working well. So if you want to come off mute, or if you want to type in the chat, this is the time where I'd love to hear about what other folks are doing.
Hi, Lindsay, this is Laura. And while folks are thinking, do you by chance have individual PDFs of the forms and checklists that you showed at the end?
Yes, I can. I'll send those separately. How's that?
That's perfect. Thank you.
Yep. Any thoughts on that? Or does it feel like a Friday afternoon and we got stuff to do, which is totally fine too.
I have been watching the chat. Most of the comments have been around, you know, getting a copy of the PowerPoint. And then also we had one about receiving the PowerPoint in advance to take notes.
Oh, that's a good idea. Yeah.
So I can work with you on that, but I'm so happy you guys want to take notes and
yeah, that's great. Because, you know, I mean, I think that makes sense too, because then we can really, you know, have these discussions and that, you know, you all can ask questions throughout the presentation. You know, obviously there's slides that are not conducive to reading on a screen. So happy to share these slide decks in advance.
This is Rachel with the Physicians Hospital. Can you hear me?
Yeah.
Hi.
Hey.
Thank you so much for this webinar. And I was just going to comment that, you know, we are using, you know, we have our IDT meetings weekly and do the discharge callbacks and have some tools in place, but we're also in the process of, you know, improving and revising our entire like IDT case management processes. And one thing we identified through some training is that the nurses, the staff nurses that have direct patient care with the patients, there may have been a disconnect with communication as far as what the patient goals are. And so things that we're working on using some tools are, we have the whiteboards in the patient rooms.
Yep.
So clearly stating what the patient goals are. And that way everybody that has direct care with the patients are able to visually see what those goals are daily and then reinforce those. And then also including our staff nurses in a rotation. We're not sure exactly how it's going to look yet, but including them in the IDT meetings, because we have kind of a swing bed coordinator that attends all the IDT meetings, but we find value in having not only the nurses and the entire therapy team and all that, but respiratory therapy team and then staff nurses attend those as well. So we're excited about, making some changes there.
Yeah. I mean, I think you brought up two really great points there around leveraging the whiteboard. A lot of some whiteboards have, patient goals for today. Sometimes they're not, as fancy as that and don't have that. The other thing is around adding the anticipated discharge date too, to your whiteboards, whether that's for your acute patients or your swing bed patients. That anticipated discharge date kind of ties back to some of the goals, and you can have that conversation with your patient about, hey, if you can meet this goal, we can meet that discharge date. And obviously those things need to be constantly updated. And around the having staff nurses, kind of rotate through on the interdisciplinary team. I mean, I think that's a great idea. We often, make that recommendation around if you have, your quality committee for your hospital, and making the same thing, having your frontline staff rotate through those quality committee meetings. A lot of times they're just not getting the information. It is our process that managers share information with the frontline staff, but sometimes, through auditing our frontline staff, we know that information isn't necessarily always getting there. So, having them, attend those meetings, gives them, a sense of ownership too in that patient care, and understanding kind of we're doing these things, and there's a reason why we're doing them, if that makes sense. But great. Anyone else sharing what's working, what's not?
This is Joey from Newman Memorial Hospital in Shattuck. Can you hear me okay?
Loud and clear. Yep.
Okay, great. We're also doing the weekly interdisciplinary swing bed meetings. And one of the things that we've started doing that I think is going to down the road have a really positive effect is asking the patients and the family during those meetings, is there anything that we're doing or not doing, that we can do to improve? Is there anything that you have any complaints? Is there anything that we can do better? And that way, when we do those post-discharge follow-up quality assessments, whether it's calls or surveys, hopefully if they have an issue that maybe they perceive as minor, that we can fix while they're there, then that will be reflected when we do those quality measures later.
Absolutely. The other thing to do is, the patient rounding, or, having leadership rounding on patients to also get that real-time feedback, is really vital. So you can do any type of service recovery right then and there, and not have to wait until you make a post-discharge phone call and find out that something went terribly wrong during their stay. Those are great check-ins where we can really make some changes right then and there. Good. I like it. Sort of off topic with the remaining time that we have, and it's similar to what you had just shared around, involving the patient getting, or the patient's family and getting, what can we do better feedback. Does any hospital, does anyone have a patient family advisory council? No. Okay. Is anyone interested in starting one?
I think that would be an interesting topic to address.
Okay. Okay. I think that it is certainly something to consider when you really want to get, patient, family, feedback, and I think it's the part where we're able to move the needle in terms of our customer service and our patient satisfaction. It's sometimes it's so hard to have our HCAP scores, poorly reflect, our hospital because of, just how the survey is set up, and maybe we just have low survey responses. And so it's not really reflective of our care and our competencies and whatnot. But I think having some type of patient family advisory council can start to move that needle a little bit.
Lindsay, this is Laura. In the chat, Emily and O'Keen said that they're interested. And then Felicia Rhodes in Weatherford mentioned good idea for a webinar. Do you have any templates or best practices that we could share?
For a patient family advisory council?
Yes.
Yeah, we have like a whole webinar that we can do around that.
Oh, cool.
Yeah, so that, I know that this is swing bed related, but I think, having the development of a patient family advisory council certainly is applicable to the whole facility. So that might be a consideration, because I don't think that we have a webinar topic for the next webinar. I don't think so.
That sounds good to me. And we just had another comment in the chat. So
okay.
I was going to ask you what was going to be next. So it looks like we got it.
That was going to be my question to the group is, are there any, and feel free again, if there are any questions that you didn't ask during the webinar, or any comments, certainly feel free to email me. And we can, or if you have another idea for another webinar that we'll be doing, feel free to get that idea or suggestion to Laura or I. But it sounds like we've got a topic, so that's exciting. And so we'll get to a date on the calendar so we can all be on, and this will be good because we'll start to share some all about PFACs, which is, I think they're great. I think it really, like I said before, it really moves the needle around your customer service, organizational wide. So I'm excited for our next time we get to meet, and I think I'm almost at time. So I'm going to let you all get out 2 minutes early. And so thanks for attending. Again, let me know if you have any questions, anything. If I can't answer it, I'll certainly dig deep and get an answer for you. So feel free to let me know if you have any questions.
All right. Thank you, Lindsay. And thank everyone for attending. My homework, I will work with Lindsay to get a date for our next webinar scheduled, and be sure and send out the registration link. Also, I will send this recording to my colleague to get it on YouTube, and I'll send everyone the link for that, as well as the slides and the PDFs of the checklist and forms. So in the meantime, if you guys have any questions at all, please do not hesitate to reach out to me, and y'all have a good rest of your day. Thank you all.
Punch.